Good afternoon. Welcome to today's webinar, Real Talk in Long-Term Care, Leadership, Culture, and Reform from the Inside Out. Presented by me, Leander Alexander, Public Health Specialist and Healthcare Administrator. Thank you for joining us today. Let's get to work. A little bit about me. My name is Leander E. Alexander. I'm a healthcare administrator and consultant and public health specialist. I have over 15 years of experience in healthcare and public health. 10 of those years in management, also 10 of those years within um, long-term support services. I have a bachelor's of arts in sociology and anthropology from Colgate University. Graduated in 2012. I have a master's of healthcare administration in Colorado from Colorado State University Global Campus. I graduated there in 2019. I have experience working in long-term support services, psychiatric facilities, community organizations, clinics, government agencies, public and private sectors of healthcare and public health, and my major skill set is in risk management, program and service development, and support. So again, welcome you all today, and thanks for joining. So a little bit about long-term care. Again, I've had 10 years, about 10 years of experience working directly within long-term care. This includes nursing homes, short-term rehab, psychiatric facilities. I have experience working specifically as a social service director and admissions director at one facility. I was actually both. So, but overall, because I am a healthcare administrator, um, as many of you might actually know, working with a long-term care, you might be as over one department, but of course, you are going to have many different hats, and this is the hidden reality of long-term care leadership. Okay, many of us, and I'm myself, I remember working 6, 7 days a week, over 8 hours, sometimes 10, 12 hours, just to get things done, to catch up on paperwork, to meet up with families, to meet up with residents, to keep the facility going. Okay. Because basically, we're a micro hospital. Okay. We accept people with all types of different medical conditions, medically things going on with them. They're going through many medical events. So we're a micro hospital managing all of that. Okay. Not just with passing medications, make sure they get to appointments, in-house treatments. I know there's a lot of facilities that have a dialysis center actually a part of their facility. So managing all those services like a little mini hospital. Okay. Social agency. Okay, we are a social hub. Long-term care facilities are social hubs of the neighborhood. Okay, usually, think about it from a business standpoint. Home health care agencies coming out to see you. DME agencies coming out to see you. People in the community who loved ones need support or short-term rehab. They're coming to see you um, because we provide a service that's in demand. Okay, so we also have to manage a lot of the needs that fall outside of the medical concerns that our patients are having. Okay, so a lot of them are going to have socioeconomic needs, mental health needs, behavioral needs. Um, maybe if they're just here for short term, okay, yeah, we have them in house, but when we want them to get back, they're ready to go back to the community. We got to make sure they're well supported. They might not have the financial resources or the support in the community needed. So things like that. When I say we're a social agency, okay, and then we're also a compliance zone, okay. Think of all the we work in healthcare. Healthcare is of course regulated. With the regulations comes compliance, and failure to be in compliance is what fines. Which so we have to deal with all that. Um, so being a leadership in management, dealing with that, running a micro hospital, a mini social service agency, and having to follow these compliance, that's a lot of emotional labor. Okay. You're working 5, 6, 7 days a week. Don't let stay come in on your weekend off. Then you got to go in and deal with that. Okay. So it's very heavy. And what I'm finding is we're seeing a lot of turnover, not just in line staff, but in management as well, because management is getting burnt out. I can raise my hand and say I was getting burnt out. Okay, but I still love doing what I do, and I still want to help this field. I still want to help professionals who work in this field and bring on new people because we need help in long-term care. This is a critical service that is provided to the public health. Okay. Again, and I explained this in the webinar I did yesterday. We work in a demand field. The service will always be needed. In fact, it's actually going to grow. So these facilities are needed. Our structure is needed, but we have to change the culture. If this we're going to keep or we're going to change the long term care industry to really thrive, because right now it's a lot going on, but to really thrive, we're going to have to start with changing the culture of these facilities, of the management of our line workers. Okay, doing that is going to provide better support for your patients. Better support for your patients means you get more heads in those beds. Okay, so culture over compliance. Okay, I do believe a lot of long term care facilities operate over this idea of putting compliance over culture, actually. Okay, what do I mean by that? You just want to make sure something's in place. You got a policy in place. So if the state comes in, they look at the policy, there's no issues. At least that's how you want it to be. Or you're not really following in-service guidelines. So like a popular one is the state comes in, they might see something, there was a tag or something. Now the management is running around doing all these in-services, okay, to keep in compliance. Whereas you had a culture, you would have in-services trainings scheduled either monthly, quarterly, however you want to do it for your staff members, okay? To do those compliance trainings as well as provide staff development. Okay. If we want to provide quality care and have a good supportive culture, you have to invest in your people. Okay. You don't necessarily have to go out and buy $1,000 of training per se. Thinking about what you could do in house. Okay. Or I'm a healthcare consultant. I do offer to do virtual trainings, scheduled trainings, systematic trainings, workflow trainings to your staff um, systematically. So that's what I do. And you don't, again, it's not expensive. The reason you want to do this, again, is because you want to really improve your culture in providing care. Okay. When we think about compliance, the one thing you think about compliance is the fines, of course, right? You got to pay the fines, there's always penalties and whatnot. But compliance, one of the easiest ways to get yourself out of compliance or out of risk for not being compliance is to focus on providing quality care. So instead of focusing on I don't want to get this fine, I want to make sure my patients are well supported. Okay. Because policy does not equal trust, relationships do. Okay. With your patients, um, y- you can't just see them as a template. They're individualized people with individualized need. Okay. When we're thinking about the care of our patients, especially when we're doing care planning and talking about the overall clinical state of the patient, what every department head, what every staff member in the facility should be asking themselves: number one, do care plans um, reflect the resident or the regulation? Does our clinical plan for this patient reflect regulation or the resident's needs? Does anything we do for this patient just go by regulation, or are we actually adhering to the patient's needs? Key point, you could still be following regulation. I mean, you could be following regulation, so you think in compliance, and meeting the patient's needs per regulation. But if you're not doing your full diligence and you know or lack thereof knowledge because of failure to assess or failure of culture that you're still doing not enough, guess what? That patient's going to experience a decline because you're not doing what's needed to be done to keep that. So that's why you keep having all these rehospitalizations. You're doing in compliance, but we all know that sometimes compliance is bare minimum. Remember, we're an industry that works with people who are sick. They're sick. They're in need of care. A lot of times we're meeting them at points of crisis. Okay. So is your care, is it trauma informed? Okay. When we're meeting our patients, we're meeting them either in an adjustment where they can't live on their own anymore. Now they're becoming long-term residents. They're moving in with new people. There's new structure. There's all these new rules and policies that they have to adhere to. Like maybe they can't smoke in their room, or there's a curfew, or they have to be at least be back in the building by a certain time. There's all these rules in place from people who might have been living freely, but now because of whatever reason, medically or behavioral need, they're going to need that 24/7 care. Or maybe they were at home, being able to be independent, do everything, but now they got a broken leg or broken hip or something, and now they're going to have to be spend a few weeks in a short-term rehab. It's going to be a new experience. Okay. On top of social services, no, we don't know what they experienced in their lifetime. They could have been um, subjects to all types of abuse outside of the scope of care we're providing for them. Okay. That's the whole needs of a patient in healthcare, and I'm going to stand by this. You have to let's look at more than what they medically need. You want to look at the overall wellness and then build a culture about the wellness, not just of the patient, but of your staff members. Are the patients okay? Is the nurse on the fifth floor okay? I wonder how that CNA who was uh who was so nice to do a double shift. I wonder how she's doing. Did I tell her? Did I thank her today? A culture, a culture of support, a culture of guidance. Okay, and then when dealing with patients, but also with other staff members or linemen, do we react to behaviors or explore the root cause? With patients, again, we come across patients where they're in needs of crisis. I always say this is one of the things I stress as a social surgeon, especially working with when I was working with mentally ill patients who would just cuss you out on a whim. I'm not saying you don't have the right to be upset about it. Of course you do. That's valid. But also that's when you need to take a deep breath. Being a healthcare professional, take a deep breath and remember it's not personal. They're upset at the system. They're upset at what happened to them. They're upset at their insurance. They're upset at their doctor. It's not on you. That's when you just step back. And oftentimes, and I say this having been in that situation where the patient's going off, I just, you know what? Okay. I understand you're upset right now. I don't want to upset you anymore. I said what I had to say, or, I want to say like I said what I had to say like that, but, do it in a way just like, I'm going to back off because I don't want to continue to cause you any harm. Say it nicely, maybe a few hours the next day. Good morning. Good morning. How are you doing? I hope everything's okay. Hey, let me know if you need anything. Just, I'm the first one who's going to greet them, in a good, impressive manner, and they're going to probably feel bad about it. So like, wow, I was a real, oh, okay, but that's how we do it, and then they'll be like, okay, well, they could calm down, like, you know what, I was overreacting. You were. I've had it happen countless of times. Countless of times when you meet the resident or the patient that something's going on with the family, they're in an uproar because whatever happened at the hospital, whatever happened to insurance, whatever happened at the facility, and now you have to handle it. Just want to calm down. Keep it quiet. If you got to step away. If it gets you to a point where I can't handle this, hey, I got to step out. I know we're working in social service. That's one of the things we have to deal with the behavioral management. Sometimes, like I got to take a step back. I was looking up to always have my director or my other coworker or me. I had to step in, being the director, um, to support my linemen. So like, you need to, hey. And even then, without a director, I could go to my linemen, my PRSCs, and be like, hey, I know I'm direct, and they'll be like, there's teamwork, there's support, there's guidance. Okay, so when we're thinking about behaviors, um, don't think about it in terms of just the patients. Think about how your communication is with other staff, with other departments. Okay, I know there's some facilities that might have some inter-department strife for various reasons, but we really wanted to get a control of that because at the end of the day, it's not one against the other. We're all here as a team. Guess what? The patient who cussed out the nurse, cussed out the dietary aide, cussed out the activities aide, child, we all got cussed out. But you know, we all here, we all love what we're doing. We're all here to support the patients. Okay. Discharges and dignity. Okay. Discharge planning is public health matter. Okay. Why is that? Poor discharge can lead to, and often actually do, verifiably lead to increased risk of crisis. Okay. Advanced directives often are outdated and ignored. Discharge should be prevention, not a paper trail. So let's talk about those different points for a minute, okay? Poor discharge equals increased risk of crisis. We all know that once the patient discharges from a short-term or nursing facility where they was doing short-term rehab for like 2 or 3 weeks, they go home. We do not want that patient to be go back to the hospital at least within that 30 days. Why? Because the way the Center for Medicare and Medicaid works is if they do, there's going to be some type of penalty in your reimbursement. It was designed as an incentive for long term care facilities to make sure they are providing quality care. It's basically forceful. Hey, when this person discharged, you better make sure they're taken care of. Continuation of care. Okay. Poor discharging, poor planning, basically is we're not sending home or we're not um, making sure that the patient is discharged for the appropriate needs. This could include any medications needed, any DME equipment, home health services, at the very minimum, those three. Okay. Um, Not making sure that's coordinated properly, which usually does fall in social services. And yes, everything runs through social services, but I could say, being a social director who did that, it still is discharge planning is a team effort. Okay, I need doctor's orders. I need therapy, whatever final notes therapy has, and what the patient needs to do. Okay, um, I need nursing to make sure the medications are proper. I need business officers to make sure all billing and insurance stuff has been verified, and if the patient needs it has any invoices, that we get that out, or I can include it in the um, discharge packet. There's so many moving factors that's needed from everybody on the team to make sure this patient is going to discharge safely. Just like in my webinar when I said it's a team effort when they're admitted, it's a team effort to make sure they're discharged properly. Okay. You want to make sure too that your advanced directives, any POA or guardianship information has been updated too. And that it goes with them in their discharge packet for continuation of care, because if they ever do have to go to the hospital or another facility, they'll always have that. That should be something that's part of the medical record anyway. Usually, my word of advice for that is if they're coming from the hospital, especially if they're actually going to be admitted for long term, see if the hospital, the social worker, one, could get the POA or guardianship forms if there is one. Two, if they do have an advanced directives on file, but if not, when they get to the facility, you can easily do that one. At the very least, you at least want to educate them about those two things and document it to show that due diligence was done. Okay. You should also be documenting the different services that you do set up with discharge planning when you're doing the discharge. So documenting what home health they were referred to, documenting what equipment was ordered, document how they're leaving the facility and who they're leaving with, document if medications, um, if the medications that were given or sent home, all of that. You want to make sure that's documented, okay? Now, with all that being said, discharge should be prevention and not a paper trail. Yes. Now, yes, we want the paper trail. Yes, we do. But again, we want to make sure it's preventive, not only in compliance to make sure we're not skipping or don't mess up our reimbursement, which is a good incentive, yes, but for the care and just to support the patient. Okay, if this patient is discharged from your facility, receive good services and care while they're at your facility, and was set up to continue success in the community, guess what? You got a free marketing tour right there. They're going to tell all their friends and family, you need to go to this facility. They did this, they did that. In healthcare, that is how patient marketing works. Word of mouth in healthcare is your best friend. Not only that, it's just good service. It's good ethically. Okay. Again, we get too caught up in the whole money and the profit. And yes, that's important, but I do believe that quality care will lead to profits. That's literally how they're designing it. The incentives. Quality care leads to profits. Now, I get the quality care. There's a lot of issues in managing that, and that's why I'm doing what I do because there is ways to do it. It's going to take work. It's going to take leadership. It's going to take a change of culture. Okay. So best practices when you're doing discharge too is also to plan with the patients and residents, make sure they're well supported. I always ask the patient, "Hey, what are you going to need to feel safe upon discharge?" For short-term rehab, that's the first question. The first question on the first day I ask, "What are you going to need to discharge?" Involve family and community. Involve the family. Any neighbors, any community sources that the patients might be linked to already, like church or another or a social service community social service organization, and then follow for care continuity. Um, I will say this for discharges, it's very key that you work with very good home health care companies. You said there was a good home health care company. I know some amazing home health. The reason you want to do that is because that home health is going to make sure they not go to the hospital because they know we want to make sure your discharge don't go to the hospital. They don't want them to go to the hospital either because they're not going to get paid. But having patients that one they go to the home health care service. They're not hospitalized because the home health continues good care service. Everyone wins because no hospitalization. And guess what? The facility is going to like you because they're going to notice that every time we discharge a patient with you, we have no issues. There's no hospitalizations. There's good follow up. So that means for home health, you're going to get more business. Okay. I know we're talking about culture and patient, but I got to throw in a little business tips here and there too. All right. So the main elephant in the room, and I know this is a huge, huge topic, not just in long term care, but across the healthcare industry. Staffing, 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 staffing. I know a lot of owners were happy when they did reverse the staffing rules. I think what they did, they held off for 2 years, but they reversed that because everyone was going crazy about that because we're already finding it hard to keep staff in house. Not only line staff, but department staff, the manager staff. Okay, usually the turnover for nursing homes, long-term care facilities, I have a staff member who's there for maybe a year, 2 years, maybe at most 3 years, and then they're out. Why? Because of burnout. Burnout is more than HR. It's care quality too. If you continue to have a turnover of staff because they keep getting burnt out, or you have staff there who continue getting burnt out, they're not going to be focused on quality care. They don't have the energy. They're burnt out. Or they don't have the consistency. There's no consistency in staff because every few months or weeks there's a new nurse, there's a new social service person. So there's no consistency in care for the patients, which leads to decreased quality in care for there's decreased care for the patients. Okay, overworked management. Miss, how many times I just said not too long ago, a few moments ago, about working 6, 7 days a week, sometimes 10 hours a day, 12 hours a day, still being at home, still being on call. If something comes up, you got to go back to the facility. If state comes in, you got to come to the facility. Your staff might be always calling you, even on the weekends when you might be off, because things are still happening in the building and you're the department head. Okay. 9 times out of 10, you're probably not getting paid nearly what you should be getting paid. Okay. Which is also the big thing, too. Overwork management, because that means we're falling so much falls on management. I know. Oftentimes, in a lot of facilities, not only is the manager having to just manage the department, they're often having to do the responsibility the linemen are doing either because of lack of staff or because of burnt out linemen themselves. Okay. So this leads to miscare, poor outcomes, which means decrease in CMS quality measures, which means your reimbursement rates go Again, just add a little business. You see how it all ties in? Quality care, profit incentives. Incentives. Okay. Emotional labor deserves recognition. Okay, I just brought up that wages, of course, are a big thing too. Um, Honestly, I'm gonna be honest with you. A lot of us are underpaid. Let's keep it real. A lot of you administrators, if you're an administrator watcher, you know your not only your lineman staff, your management staff is underpaid. You might be even getting underpaid. Okay, if you find yourself in a position or as an administrator where maybe for whatever reason you can't, or for you can't do anything about the wages, or you can only do so much. This is where creating that culture of support, of guidance, of understanding, of wellness within your facilities is going to come into play. Okay. For example, when I was working the 6 or 7 days a week, sometimes 10 to 12-hour days, I was exhausted, yes, but I was doing it because I knew I was working for an administrator who looked out for me. So guess what? If I had worked, maybe had worked a few hours over, like you know what, just come in a few hours, just come in a few hours late tomorrow. Like you was here till 8 or 9 o'clock tonight. I know you usually start at 8 o'clock, 9 o'clock tomorrow. Why don't you just come in around 11? We can manage it for the few hours. Or for a lot of director of nursings who are working 6, 7 days a week, hey, why don't you take 2 or 3 days off? Don't worry about we'll keep everything covered. Finding ways to do that. Um, if you for lineman staff, appreciation, just even verbally. Now I know there's a whole bunch of jokes about the pizza parties and whatnot, but even bringing in morning donuts, you know, like hey, I just brought some donuts and coffee. I know working in healthcare, I know long term care. I think we're all just avid coffee drinkers. Okay, we have to be something like that, something as simple as that. That goes a long way. You know, a lot of times and let's keep it real. A lot of us work in the field. We know we're not getting paid, but we're there because one, we love what we do. We love work with the patient, and two, if you're lucky enough to be in a place where there's a good culture, a good supportive culture, then I want to. It kind of balances out. I'm not saying that you shouldn't go for earning your the wage you so desire and so you deserved, but as we work out these kinks um, in long-term care, this is going to be one of the things we have to look at, changing the culture, because actually changing the culture can actually build your profit, which means you'll have more money to give to staff. Okay, why change the culture? Again, because changing the culture improves your patient care quality measures, and it improves your how patients view your facility. If people want to come to your facility, that's wonderful. Head to bed. So really changing the culture is, and this might people might say, oh, this is just so you know, uh, people might have some type of thoughts about it, about this, saying that, oh, it's just not enough, or oh, it's more to that. No, this is. You have management, lineman staff burning out. You having to how many hire fairs have you had a week? How many interviews you're doing a week to replace the same position over and over and over again? How much is it cost you to replace these positions? How many months, weeks has these positions that you critically need been vacant? Many people quit or you have such a high turnover because of the culture. So you can say this is important or it's not that big a deal. Yes, this is a big deal. This is why people are leaving long term care. This is why you're having issues finding staff. Put aside the wages for right now, just with the culture alone. So you want me to come to work, be paid, underpaid, and deal with mess and deal with a toxic culture? Oh no. For what? Because let's be real, working in healthcare, you can get a job anywhere. But you want the best staff to be with you. You want the caring staff. So you want caring staff, you got to be willing to provide that care to them as well. As an administrator, you should be walking your floors, walking the hallways, engaging with staff, having weekly or periodically or scheduled meetings with individual meetings with your department staff. Don't just make it when you first come in or whatever. Do it on a scheduled basis where you get to listen with them, learn what's going on with them, and how you can best support them. Same thing with department heads. Do this with your lineman staff. Support and guide. Support and guide. Your residents are part of the community. Okay. Long-term care is not a bubble. Oftentimes, though, it is because we have patients, long-term care. We have patients who, again, they're patients. They'll come through our facilities, long-term care specifically. Come, we'll get them acquainted. The family might be out, the day in. They might come and see them. They might be there that weekend. They might be there for a week after. But then gradually, since they're going to be there aging in place, there's not as many visits. The phone calls start coming in. Holidays, they used to go out, now they're in the facility. Just because maybe it's just too much, either medically or the family or whoever can't manage their medical conditions, or they got other things going in their lives. And because the patient resident requires so much care, it's just safer and easier to keep in the facility even for holidays. So now you have the patient there, the resident there, who might be just sitting in their room, looking out the window, remembering the times where they were engaging, that they were a part of the community with their own family and friends, but now they're just there. I want you to think about that when you were thinking about residents of these communities. Okay? They are voters, veterans, neighbors, mothers, brothers, sisters. They've had grief. They hold grief. They've been through trauma. They've experienced joy. They've, I cannot tell you, and everyone knows this working in long term care, you come across amazing, amazing people who've done incredible things, who have amazing life stories, which is one of the reasons I love, again, love doing this. You meet so many people from so many walks of life. Just because they're in your facility does not mean they are not part of the community. Okay? Engage them. One of the, as a social service director, this was my main thing. Who are my isolators? I wanted them to get engaged. If they're going to stay in the room, we're going to come visit them. I need to know that you're okay, and I want to make sure you're okay. I want to support you. I want you to remind you that no, you're not just a nursing home resident. You're so and so. You were this. You did this. This is what you enjoy. Okay. Build bridges too with your community. I call it the health ecosystem in your community. Okay. Churches, places of worship, community health programs, volunteers. Um, there's a lot of cultural communities, groups too within the different neighborhoods. Get involved with those. Reach out to them. Invite them to come in. You can invite. I know a lot of nursing homes, they'll invite talented, so people from the community who might do music, or who might do poetry, or who might do knitting and crochet. They'll come in as part of the activity and do that with the residents, with their patients. Get them involved with the elite with community. Again, this is also a great marketing strategy because it lets the community know, hey, we have this nursing home here. They provide great support. They just had a free um, crocheting event for their patients where a volunteer came in and worked with them. That's a place where I would want my mom and dad to go, or if I would want to go if I need long-term care services. Your residents, your patients are a part of the community. They're not just billable beings. They are humans with a past and a present and hopefully a future. Okay? So, the best way to really take action and start reforming your culture of your facility is to do it all to yourself. And you want to reform from the inside. Okay. Internal change leads to systemic change. Internal change involves behavioral and mood. So this is where you got to start thinking like a social service director. I want to get the patient to take their medication. Systematic. Take their medication, they're gonna be all right. I ain't gotta worry about them, no issues with that. And we keep them with the compliance, right? Internally, I might see so John Doe, why don't you want to take your medications? Figure out what the root cause goes back to understanding what the root cause is, and then working through that. Do it with your facility step by step. Um, find out, and I know you're gonna hate this. Find out what the staff concerns are. Yes, it's gonna be wages, but guys, there's more you can do than just wages. Is it um, ways to um, ways to reduce certain workflow or processes that makes their job easier, so they're not stressing as much. It could be as simple as bringing in donuts and coffees to Monday morning every Monday morning meeting. It could be simple as doing a potluck or doing some type of event quarterly for staff, just appreciation event. Okay, if you can't spend a few $100s to do that for a staff at least quarterly, then are you really serious about really making true change and making money in this field? That's all I'm gonna say on that. It's not radical. Again, it doesn't have to be this whole major event. It could just be something as simple that you could do tomorrow or the next day you go in. You could just go get some donuts and some coffee. Hey, I brought everyone donuts. For your staff, for management, for whatever meeting. If you know, for because I know because working in long term care, we're around each other so much, we ought to become each other's kind of family outside of the family. A lot of times we share maybe personal things that's going on with each other. So maybe that there's a coworker or your fellow manager who might be going through some personal stuff that they share with you personally. Maybe just like, hey, I was thinking about you. I hope everything's okay. Let me know if there's anything I can do to support you in your work. Building that support team. As a team, you should ask what's practice versus what's documented. Get out of that phase of just wanting to be in compliance. Okay. One of the things I like to say is when state comes in, there shouldn't be a whole hoopla running around because guess what? If you're doing what you're supposed to do, you got to worry about it. Now. Granted, yes, it might be a little bit certain things you might have to fix this, but it should be a whole major. If the state walks in and your facility has to do a whole flip, you are in a most definite red zone. Okay, that's not how it should be. The culture should lead to practice, and the practice should be documented truthfully in the documentation. It flows together, no compliance issues, no fines. You have supported and guided staff. You have a thriving patient population. Who do we know personally among our residents? Get to know your residents. Remember, they're part of the community. What are some ways we can get them engaged? Now, you granted, you cannot. I'm not saying you're going to be able to get every person who's isolated in the room out the room today, tomorrow, the next week, next few months. You might not even be able to do it because. But if you don't know they're not coming out the room, maybe just going to their room to see how they're doing, talking to them. Hey, maybe taking 5 minutes or 10 minutes out your day just to go see how they're doing and talking to them. That makes a difference. It does. It makes a world of difference. Where can we shift from reactive to proactive? And this is my favorite point. This is why I started Edward Lee Consulting to work with long-term care facilities and providers because so much of this industry is reactive. You're reacting to the fine. You're reacting to the state being in the building. You're reacting to the lawsuit. You're reacting to the medical event that the patient's having. It's always in reaction due to the culture of burnout, of over of uh, lack of support, of lack of staff development, of lack of staffing, all of that is leading to the industry being reactive, which is not a good place to be in healthcare. The best place you want to be in healthcare from a quality, patient quality, care quality standpoint and a profitable standpoint is to be in preventive action. Preventive action. Now, can we always predict what's going to happen? No. Preventive action involves active studying, active um, conversations, active um, support, active communication, active. Everything has to be active. Okay. Preventative. Part of being institute preventive care goes into the culture. Having a supported and guided staff who wants to come to work, who's going to be feel supported to come to work. Like, yes, it's stressful. We all know that. And let's just say that working in healthcare is stress. We all that's just a given. Working in healthcare is going to be stress. But it's one thing to come to a stressful environment and know that I'm going to be supported. Because then I'm able to do my job more efficiently and effectively, which does well for the facility and the upline and well for the patients. Okay. Preventative, and I preach this a lot too in many of my seminars too. I mean my webinars, sorry. Is that prevention leads to decreased fines, leads to decreased risk. Preventive involves assessment. This is why you should be auditing audit your facility to see where its culture is. Because if you are having a culture where there is burnout, where there's not any staff recognition, where there's a high turnover rate, then ultimately your business can't be making money. There's too many risks that's going unwatched and unfixed because there's no stability, because the culture is just toxic, whatever words you want to use. It's time for us in long term care to start getting serious about these conversations. It's time we start really taking the time to do the work to make this change come. Okay, so here are my final thoughts. You know the work, let's make it better. You don't need permission to lead culture change. Again, if you're a department head, or have you, it's nothing. Just again, if you can afford it, get just a box of donuts and maybe the things we call from Dunkin' Donuts, or whatever. Uh, uh, bring it to work. Hey, I brought this for the staff for our meeting. It can be for a meeting. It doesn't be for. It can be for a civic meeting. I know Medicare meeting would be a great meeting to do that in. Um, but just something. It could be something so small, or it could be something that's. You know what? Thank you so much for dealing with that patient yesterday. It's just it that appreciation, that I see you what you did and I recognize and I thank you for that. That goes a long way. Just to let you also too know, I do offer services. I do offer in-services survey prep and social services support through my consulting services. So for more information about that, you could go to edwardleeconsulting.com. That's EDWARDLEE consulting consulting.com. And remember, this is about support and not sales. Okay. I'm here because yes, I want your facility to be profitable. I want your facility to be making money. I want to increase that fixture revenue management. But to do that, I truly believe in strategic planning that involves understanding and fixing the culture and workflow processes of the facility. Because I'm telling you right now, that is the key issue, one of the key things you can really fix to really change that revenue flow. Okay, changing your culture, changing your emissions and marketing strategies, getting that more lined up, understanding how your facility operates, and learning how to leverage that and grow it. That's the services I provide. So if you do offer to go to my website at www.edwardleeconsulting.com, you can also email me at lalexander@edwardleeconsulting.com. And also we're here on YouTube, Edward Lee Consulting. As always, thank you for joining. Make sure you please like, share, subscribe, and hope to see you again soon. Bye.